Hello dear friends, in our series of applied neuroanatomy, today we are going to discuss the anatomy of a very important region, which is the anatomy of the orbit. As you know, the orbit is no man's land. It is shared by different specialties like neurosurgery, otolaryngology, maxillofacial surgery, and ophthalmology. Also, it is the site of many great variety of pathologies in this small region you can find there. So, having a good knowledge of the orbital anatomy is very important because many of the orbital lesions are within the armamentarium of neurosurgery. The orbit is a symmetrical paired structure on either side of the midline, separated by the nasal cavity and paranasal sinuses. When we talk about the orbital anatomy, we should detail it into bony orbital anatomy, orbital fascia and dura, orbital muscles, orbital nerves, and the orbital vessels. The bony orbit is formed of 7 bones, forming the 4 walls of the orbit, the roof, the floor, the medial and lateral walls, and you can remember the 7 bones by many friendly zebra enjoy a lazy summer picnic. This is the maxillary, the frontal, the zygomatic, the ethmoidal, the lacrimal, and the sphenoidal, and the palatine. And it contains nerves, vessels, muscles, the globe, and fat in between. Orbital septum is a connective tissue structure acting as a barrier between the facial skin and fat and the orbital content, preventing spread of infection. The bony orbit, as we said, it has 4 walls, roof, floor, medial and lateral walls. The orbital roof is formed of the orbital plate of the frontal bone anteriorly and the lesser wing of the sphenoid posteriorly. Orbital floor is formed by the orbital plate also, but of the maxillary bone, the palatine, and the zygomatic bone. And the medial wall is formed from the front to the back by the frontal process of the maxillary bone, by the lacrimal bone, by the ethmoidal bone, what we call the lamina papyracea, a very thin layer of bone, the medial wall of the orbit separating it from the ethmoid sinus, and the lesser wing of the sphenoid. The lateral wall is made of the zygomatic bone anteriorly and the greater wing of the sphenoid bone posteriorly. It's very easy to remember, and I'll show you how now. Look, let's talk about the roof first, then the floor, then the lateral and the medial wall. The roof is made by the orbital plate of the frontal bone. The bone in blue is the frontal bone, and this is an orbital plate forming the roof of the orbit. So this is part of the roof, and the lesser wing of the sphenoid, which contains the optic canal. So this is the roof, orbital plate of the frontal bone anteriorly, and the lesser wing of the sphenoid above the superior orbital fissure. The floor is made also of the orbital plate, but of the maxillary bone, because the maxillary bone is below the orbit. And the floor also is made of a part of the zygomatic bone anteriorly. So, zygomatic bone, orbital plate of the maxillary bone, and the palatine bone. The medial wall, from the front to the back, by the frontal process of the maxillary bone, which is the green bone here. Then the lacrimal bone, which is a small bone containing the lacrimal sac. Then the ethmoid bone, separating the orbit, medial orbit from the ethmoid sinus, lamina papyracea. And the lateral wall is formed anteriorly by the zygomatic bone and posteriorly by the greater wing of the sphenoid, which is below the superior orbital fissure. So, again, frontal bone, orbital plate of the frontal bone, and the lesser wing of the sphenoid. This is the roof, orbital plate of the maxillary bone, and the zygomatic bone. This is the floor, and zygomatic bone, greater ring of the sphenoid lateral wall, then the frontal process of the maxillary bone, lacrimal and ethmoidal bone forming the medial wall. Again, roof, frontal bone here, orbital plate of the frontal bone. Behind it, the lesser ring of the sphenoid, containing the optic canal. This is the roof, floor, orbital plate of the maxillary bone, and the zygomatic bone, part of the zygomatic bone. The lateral wall, anteriorly the zygomatic bone, posteriorly the greater ring of the sphenoid, below the superior orbital fissure, and the inferior orbital fissure separating the greater ring of the sphenoid from the orbital plate of the maxillary bone. Last one is the medial wall by the frontal process of the maxillary bone, by the lacrimal bone, by the ethmoid bone. And the palatine bone, you can consider it part of the medial wall, you can consider it part of the floor. It is at the junction between them. Orbital fascia. The periorbital fascia or periorbita is very important because you should know your plane. You should know, it's very important inside the fat to know where you are exactly in the orbit. Orbital plane is very important and should know where is the orbital fascia. The orbital fascia is called the periorbita, is loosely attached to the orbital periosteum. And upon reaching the orbital apex, as we'll see now, it reflects on the optic nerve sheath and the extraocular muscles, forming what we call the perimysium of the myofascial cone. Sorry. And the orbital septum or palpebral fascia extends from the orbital rim, superior and inferior orbital rims to the eyelids. When the eyes are closed, the orbital opening is covered by the septum and the tarsi. Also, other than the periorbita and perimysium and the orbital septum, we have the tenon fascia or fascia bulbi, is a thin membrane enveloping the globe from the optic nerve to the corneal limbus, separating it from the orbital fat, forming a socket in which it moves. So the globe doesn't move inside the fat. It is separated from the fat by a fascia called the fascia bulbi, or the tenon fascia, allowing free movement of the globe inside the fat. So this is the view showing this is the orbital septum from the upper border of the orbital rim and from the lower orbital rim going to the tarsus, and when you close the eye, it separates the globe from the external atmosphere, from the fascia, the fat and the subcutaneous tissue of the face, protecting it from infection. And you see behind the globe, surrounding the globe, from the corneal limbus posterior to the optic nerve, the fascia bulbi. Again here, look, this is a very important diagram because it shows you there is, we all know that the dura around the brain is bilaminar, formed of two layers, and between the two layers there exist the sinuses. We said this before. So at the region of the optic canal and the superior orbital fissure, the two layers of dura divide into one layer lining the periosteum of the orbit, which is the periorbita, and the second layer of dura continues covering the optic nerve sheath, forming the dura of the optic nerve. And as you all know, the optic nerve is not a real nerve, it is a part of the brain surrounded by the three meninges. This is the dural layer of the meninges, and it ends at the globe. And here is the orbital septum, the tarsus, orbital septum and the tarsus, and here is the fascia bulbi. And this is a view from above, from the left side, showing the periorbita after removing the roof of the orbit, and the contents are deep to it, and it is encasing the orbital fat. This is the periorbita, as we said, and this is the anterior clinoid process. This is the optic nerve. This is the superior orbital fissure, and the anterior clinoid separates the optic nerve from the oculomotor nerve in the superior orbital fissure. Again, this is a view from above. After removing the roof of the orbit, always you find three nerves under the periorbita, one in the midline, which is the frontal nerve branch of the ophthalmic division of the trigeminal, V1. Laterally, there is a branch going to the lacrimal nerve going to supply sensation to the lacrimal gland, and it is also a part of V1, and the trochlear nerve passing medially supplying superior oblique muscle from the outer surface. These nerves are seen under cover of the periorbita. So on removing the periorbita, you will find these three nerves. Extraocular muscles. There are 7 muscles for the orbit. 6 are involved in the ocular motility, and 1 in the elevation of the upper eyelid. It is a very delicate and very important muscle called the levator palpebrae superioris. If it is injured, you can get permanent ptosis. So 6 extraocular muscles, and the 7th is for the elevation of the upper eyelid. Total 7 extraocular muscles. The 6 muscles involved in the ocular motility, as you all know, are 4 recti, the superior rectus, medial rectus, lateral rectus, inferior rectus, and 2 obliques, the superior oblique and inferior oblique. Although the extraocular muscles control, there is a voluntary control on the ocular motility, so that you can voluntarily move your eyes in any direction you want, yet this is a conscious effort. But without this conscious effort, subconsciously, you actually move your eyes in all directions without noticing it. So though you can do it voluntarily, yet there is a system or a reflex that makes the globes or the eyes move together and in different directions with the movement of the head, with the movement of the body. And this is related to vestibulo-ocular reflex, where the fibers meet together in the medial longitudinal fasciculus, which is present in the brainstem, the midline. You can revise it again from the lectures on the brainstem. And the 4 recti muscles have a common tendinous origin posteriorly, called the annulus of Zinn, or common tendinous ring, and is inserted, the 4 recti are inserted in the globe in front of the equator, forming what we call the muscle cone. So the origin is from the annulus of Zinn, insertion in the globe in front of the equator of the globe, forming the muscle cone. The 2 oblique muscles use a pulley-like action with the superior oblique. Superior oblique, it is moving the eye downwards and laterally. And the inferior oblique is moving the eye upwards and laterally. So the obliques are moving the muscles laterally, moving the orbit, the globe laterally. The superior oblique moves infralaterally, inferior oblique moves superior-laterally, as we'll see. This is a very nice view of the muscle cone. You will find the first muscle to be found, the roof of the orbit, in the levator palpebrae superioris. Under it is the superior oblique and then the superior rectus. So the 3 muscles, superior surface, levator palpebrae superioris, the superior oblique with the trochlea, ligamenta sling, and inserted in the globe, and the third one is the superior rectus, and you find here the lateral rectus, and here the inferior rectus, and here the inferior oblique. Of course, the medial rectus is not apparent, is present on the medial side. This is another view showing the superior oblique, showing the superior rectus, showing the lateral rectus, the medial rectus other side, and inferior rectus and the inferior oblique. This is a very important diagram, because in clinical, when I tell you test for the ocular motility, you will make the patient look laterally, what we call the abduction by the lateral rectus. That's good. And medially, this is abduction by the medial rectus it's good, but to test the other muscles, as we said, the lateral direction is for the obliques, the medial direction is for the recti. So when you look upwards, upwards and laterally, it is a function of the inferior oblique. When you look downwards and laterally, it is the function of the superior oblique. When you look upwards and medially, it is the function of the superior rectus, and downwards and downwards and medially, it is a function of the inferior rectus. And from that you see that the muscles of the recti, they move the eye medially to the globe, and the obliques move it laterally. So never ask the patient to look upwards or downwards, because upwards is a combination of two muscles, inferior oblique and superior rectus, and downwards is a combination of two muscles, inferior rectus and superior oblique. So when you tell the patient to move in different direction, use the horizontal direction medially and laterally, and a diagonal direction, not an upper and lower direction. It's very important. If you tell the patient, look up, it's wrong. You are testing two muscles at the same time. Look down, it's wrong. Testing two muscles at the same time, but you tell him, look upwards and laterally, and look upwards and medially, and then you tell him, look downwards and laterally, and downwards and medially, to test for each muscle separately. Intrinsic muscles of the orbit, as we said, we have 7 extraocular muscles. We have intrinsic muscles, 3 intrinsic muscles of the orbit inside the globe, inside the eye, which are the ciliary muscles supplied by the oculomotor parasympathetic nerve from the Edinger-Westphal nucleus. If you remember, the oculomotor nerve is present in the rostral midbrain, around the midline, and it is relaying in the ciliary ganglion, which is a small ganglion in the orbit. When it contracts the ciliary muscle, it increases the diameter of the lens during convergence. So when you do convergence, we have 3 things. We do convergence of the eyes by the medial recti. We have the contraction of the ciliary muscles, and this will increase the diameter of the lens, and meiosis. So convergence is mainly a parasympathetic task to be done. And the second muscle here is the sphincter pupillae, also supplied by the parasympathetic part of the oculomotor, and the sphincter pupillae constricts the pupil, resulting in meiosis during bright light and during accommodation. As we said, accommodation, the medial nucleus of convergence, converging the eyes, increasing the diameter of the lens, and constricting the pupil, causing meiosis. And it is supplied also by the parasympathetic fibers of oculomotor, and injury to the oculomotor causes mydriasis, dilated fixed pupil. The third one of the intrinsic muscles is the dilator pupillae. It dilates the pupil during dim light. It is supplied by the sympathetic fibers of the carotid plexus, which is present around the carotid nerve. And if you injure this sympathetic supply, like injuring the superior cervical sympathetic ganglion, you can get Horner syndrome, which is formed of ptosis, meiosis, because it causes mydriasis, enophthalmos and anhydrosis, if you can remember. And here is to show you how does it work. This is the ciliary muscle in the lateral view, ciliary muscle anteroposterior view. The contraction of the ciliary muscle relaxation of the ciliary muscle will make the zonule, which are the fibers between the lens and the ciliary muscle. When it is relaxed, the zonule is taut and the length is thin. When you constrict the ciliary muscle, you will relax the zonule to be relaxed, the zonule, and then you will increase the diameter of the length. So if you are looking to a near object, you get contraction of the ciliary muscle, which will relax the zonular fibers, and this will increase the diameter of the length for looking to near objects with meiosis and convergence. If you're looking to a far object, the ciliary muscle is relaxed and the zonular fibers are under tension. They pull on the lens, they reduce the diameter of the lens so that you can look to a far object. This is how it works. And these are the sphincter pupillae. It's like a sphincter. It is a circle around the pupil. Constriction causes meiosis, contraction of the pupil, and it is the function of the parasympathetic oculomotor. And the dilator pupillae, these are radially arranged muscle fibers. So when they contract, they dilate the pupil, and the dilator pupillae supplied by the sympathetic from the carotid nerve plexus around the carotid. And this is another nice view, anterior view. In bright light, you see that the sphincter pupillae will constrict, reducing the size of the pupil, and the dilator pupillae is relaxed. In normal light, both are equalized, and in dim light, the sphincter pupillae is relaxed and the dilator pupillae or radial muscles are constricted, increasing the size of the pupil, and there is harmony, synchronization always between the sphincter pupillae and the dilator pupillae. Bright light, constriction, sphincter, parasympathetic. Dim light, dilatation by the dilator pupillae, sympathetic. Orbital nerves, most important nerve, of course, is the optic nerve. Transmits visual information from the retina to the brain, and it is formed of the retinal ganglion cells, as you know before, and glial cells. So ganglion cells from the retina and glial cells, covered by 3 meningeal layers, as we said. It is a part of the central nervous system, and it leaves the orbit through the optic canal to the chiasm. And other nerves of the orbit are 3, 4, and 6, and the V1. They reach the orbit from the cavernous sinus through the superior orbital fissure from above downwards. We said the superior orbital fissure live free to see no at all insult. Live is the lacrimal, free is the frontal, 2 the trochlear, then superior division oculomotor to see, then no is the nasociliary, and at all is the abducent, and the insult is the inferior division of the oculomotor from above downwards. And 3, 4, 6 are purely motor nerves, although the oculomotor contains a voluntary motor nerve fibers and parasympathetic fibers. They are all motor. As you know, the parasympathetic is an efferent system, part of the autonomic nervous system, and the sensory nerve is V1. So 3, 4, 6 are motor, V1 is sensory. This is a view from above, taking out the roof of the orbit. This is the optic nerve carotid, and going inside, and you see the dura of the optic nerve, and it is separated into 2 layers, and you see here the midline, the frontal division of V1, the lacrimal division laterally, the trochlear division is medially. So this is the frontal, this is the lacrimal of V1 of the ophthalmic, and this is the oculomotor supplying the superior oblique muscle. This is the pulley of superior oblique. Again, superior orbital fissure, left side, optic nerve, optic dura, around the nerve and periorbita, and on the other side, you find the anterior clinoid here, optic nerve here, and superior orbital fissure here, the oculomotor in the superior orbital fissure. So we are drilling the anterior clinoid. If you go up, you can injure the optic nerve. If you go down, you can injure the oculomotor in the superior orbital fissure. and here is open superior orbital fissure, and you can see the optic, you can see the oculomotor, and you can see the trochlear in the superior orbital fissure on their way to the globe, and you can see here the frontal branch of the ophthalmic division of V1, and here is the trochlear nerve going to superior oblique. Other orbital nerves, as we said, the oculomotor nerve, which is motor and parasympathetic, as we said, and it carries motor and parasympathetic fibers, supplying most of the extraocular muscles and two of the intraocular muscles of the three, which are the sphincter pupillae and the ciliary muscles, as we said. And the oculomotor divides into superior and inferior division, passing in the oculomotor foramen as a part of the superior orbital fissure. So a part of the fissure is included inside the annulus of Zinn, called the oculomotor foramen, because it contains superior and inferior divisions of the oculomotor nerve, and it carries motor fibers to all the muscles, the extraocular muscles of the eye, except superior oblique and lateral rectus, which are the levator palpebrae superioris, the medial rectus, superior rectus, inferior rectus, and the inferior oblique. And the trochlear nerve passing from the superior orbital fissure under the superior periorbita. We saw it before, medially, to supply the superior oblique muscle, and it is the only nerve in the orbit supplying the muscle from its outer surface. Other nerves supply the muscle from the inner surface. And this is a view of the oculomotor arising from the intrapeduncular fossa, medial to the cerebral peduncle, passing in the cavernous sinus through the superior orbital fissure, dividing into superior and inferior division, and relaying in the ciliary ganglion, which is a parasympathetic ganglion, as we will see, so supplying motor to the extraocular muscles and parasympathetic to the intraocular muscles, two of the three, which are the ciliary muscle and the sphincter pupillae. And here are the nerves supplying the extraocular muscles. As we said, the oculomotor nerve is supplying the extraocular muscles, but the superior oblique, which is supplied by the trochlear nerve, where the nucleus is present in the caudal midbrain, here the oculomotor in the rostral midbrain, and in the pons we have the abducent nerve also supplying one muscle, which is the lateral rectus. So abducent, one muscle lateral rectus, trochlear, one muscle superior oblique, oculomotor supplying all the other extraocular muscles of the eye, and parasympathetic to two intrinsic muscles, ciliary and sphincter pupillae. Oculomotor nerve, as we said, coming from the midbrain, the motor nucleus of the oculomotor, and the Edinger-Westphal nucleus, which is for the parasympathetic, going into the cavernous sinus, superior orbital fissure, and the green, as you said, supplies most of the extraocular muscles, and the parasympathetic relays in the ciliary ganglion, supplying the two intrinsic muscles of the eye, ciliary and sphincter pupillae. And the trochlear, it is arising in the caudal midbrain around the periaqueductal region. The fibers cross to the other side through the superior medullary velum, and they turn around the midbrain, one of the structures, and the free edge of the tentorial hiatus, lateral incisorial space, to supply, going to the cavernous sinus, superior orbital fissure, supply the superior oblique from the upper surface, outer surface of the muscle. You can see it under the periorbita, as we saw it before. This is a view of the superior orbital fissure, and the tendinous arch, or the annulus of Zinn, is here, and this is medial and this is lateral. You see that the optic nerve is attached to the annulus of Zinn, passes through it superiorly and medially, and inferiorly and laterally it is separated from it, and in this place it crosses part of the superior orbital fissure forming oculomotor foramen. So if we take the lid free to see no at all insult, this is the lacrimal. Live free, this is the frontal. 2 is the trochlear. C, superior division oculomotor, no nasociliary at all is the abducent nerve, and insult, no, to see no at all insult. Insult is the inferior division oculomotor. So the oculomotor foramen, part of the superior orbital fissure, bounded by the annulus of Zinn, and it contains superior inferior division oculomotor, the nasociliary and the sixth nerve. And outside this oculomotor foramen, you can find the lacrimal, the frontal, the trochlear, find the superior ophthalmic vein below the inferior ophthalmic vein. Ciliary ganglion, we talk about it because we are talking about oculomotor nerve. It is a parasympathetic ganglion, 2 millimeters in diameter, situated right behind the globe, and it receives from the oculomotor, as we said, the Edinger-Westphal nucleus, and supplying two intrinsic muscles, ciliary muscle and sphincter pupillae, and it has 3 types of fibers passing in the ciliary ganglion. All the parasympathetic ganglia in the body receive 3 types of fibers: parasympathetic fibers from the oculomotor or from other parasympathetic nerves relaying in the ganglion, and sympathetic fibers here from the carotid plexus passing in the ganglion without relay, and sensory fibers from the nasociliary nerve passing in the ganglion without relay. So parasympathetic relaying, sympathetic and sensory without relay. Here is the view diagram of the ciliary ganglion, and you see that the oculomotor nerve, parasympathetic fibers relaying in the ganglion and giving the ciliary nerves, parasympathetic to the 2 muscles, intrinsic muscles of the eye, and the ophthalmic division, the blue line, sensation, and it passes inside the ciliary ganglion without relay, passing, forming the short ciliary nerve, or outside the ganglia form the long ciliary nerve. The 3rd type of fiber passing in the ciliary ganglion without relay is the sympathetic, the carotid plexus, and it passes without relay, supplying 1 muscle, which is the dilator pupil. Again, ciliary ganglion behind the globe, having the parasympathetic relaying in the ganglion, which is the yellow, the sympathetic passing without relay in the ganglion, and the sensory passing without relay in the ganglion. Other orbital nerves, we talk about V1, ophthalmic division of trigeminal, purely sensory, one of the 3 divisions of the trigeminal, dividing into 3 branches: the frontal, the lacrimal, where we saw under the periorbita. This is sensation from the lacrimal gland. This is supratrochlear, supraorbital nerves, giving the skin of the forehead. And the 3rd one is deep, which is the nasociliary nerve, as we'll see now. And as we said, the frontal process ending supratrochlear, supraorbital, and the lacrimal sensation from the lacrimal gland, and the nasociliary nerve divides into nasal nerve and ciliary nerve. The ciliary nerve giving long and short ciliary nerves. From the ciliary ganglia is the short ciliary nerves, and the nasal gives the anterior posterior ethmoidal nerves and continues as the infraorbital nerve. Last but not least is the abducent nerve, supplying 1 muscle, lateral rectus, passes from the cavernous sinus through, it is in the cavity of the cavernous sinus lateral to the carotid and inferior, if you remember, passing through the superior orbital fissure, oculomotor foramen to the orbit, supplying the lateral rectus. Again, the branches of the V1 of the ophthalmic division, it divides into the lateral branch, see it under the periorbita, which is the lacrimal nerve receiving sensation from the lacrimal gland. The 2nd one is the frontal, dividing into supratrochlear, supraorbital nerves, supplying the skin of the forehead, and the nasociliary nerve, which is a deep nerve. Nasociliary nerve has a nasal part and a ciliary part. The ciliary part forms branches, long ciliary nerve, sensation from the cornea and the conjunctiva, and branches to the ciliary ganglion without relay, giving short ciliary nerve for sensation also from the cornea, conjunctiva, and the globe. And the nasal part of the nasociliary gives posterior and anterior ethmoidal, supplying the dura of the floor of the anterior fossa, and continues as the infratrochlear nerve supplying the skin below the orbit. Again, laterally, lacrimal, midline, frontal, dividing into supratrochlear, supraorbital, and then the nasociliary, giving short, long ciliary nerves, gives posterior ethmoidal, anterior ethmoidal, and continues as the infraorbital nerve. Supplying also the skin of the nose. Another view, lacrimal, frontal, nasociliary, ciliary branches, and nasal branches, anterior posterior ethmoidal, infratrochlear. Also the frontal, as you know, dividing into supratrochlear, supraorbital. This is the ciliary ganglion again. And this is another view of the superior orbital fissure, and live free to see no at all. Live free to see no at all insult. At all insult. Ophthalmic artery is the first branch of the carotid distal to the cavernous sinus, and as soon as it passes from the cavernous sinus, it gives ophthalmic artery. 6% of the cases, it arises from the carotid inside the cavernous sinus, and it supplies blood supply to the orbit, the eye, and parts of the face and nose. It enters the orbit under the optic nerve in the optic canal, and in the orbit it crosses above the optic nerve from lateral to medial, and it ends at the supratrochlear, supraorbital arteries. Also, the branches of the ophthalmic artery, orbital group inside the orbit and ocular group. Orbital group includes the lacrimal, anterior posterior ethmoidal arteries, which are supplying the olfactory groove meningiomas, and the medial palpebral artery, muscular branches of course, ending at the supratrochlear, supraorbital, and external nasal artery. The ocular group inside the group, short and long posterior ciliary arteries, anterior ciliary artery, and this is the most important, the central artery of the retina is the most important of all. Central artery of the retina, if it is occluded, partial or complete blindness according to the degree of occlusion. Here is the view of ophthalmic artery, first branch from the carotid as it passes intracranially, passes anteriorly, under the optic nerve in the optic canal, then it is lateral and crosses from lateral to medial above the optic nerve, then it ends in the supratrochlear, supraorbital, and here again it gives the lateral and from above, from lateral to medial, and very important branch here behind the globe medially in the central retinal artery. So the safest part to approach the optic nerve is from anterior lateral. Lateral posterior you might injure the ophthalmic, and medial anterior you can injure the central retinal artery. So if you want to keep the blood supply, approach optic nerve from lateral anterior. Another view, ophthalmic, lateral to medial, ending supratrochlear, supraorbital, anterior and posterior ethmoidal, muscular branches, central retinal artery, and short and long ciliary arteries, posterior and anterior ciliary arteries. Orbital veins, very important. They can transfer infection from the face, from the dangerous zone, to the cavernous sinus and result in cavernous sinus thrombosis. They are usually superior and inferior ophthalmic veins. The superior and inferior ophthalmic veins drain into the cavernous sinus. You know the veins have many variations, so you can find each vein draining into the cavernous sinus, or the inferior vein draining into the superior and the superior draining into the cavernous sinus. Many variations you can find, and the most important of the orbital veins is also the central retinal vein, which drains into the superior ophthalmic vein, and it passes in the substance of the optic nerve. Its occlusion can cause blurred vision and total blindness. So this is the venous system, superior inferior ophthalmic veins. This is the superior ophthalmic vein with the tributaries. This is the inferior ophthalmic vein, and here the superior and inferior ophthalmic veins draining into the cavernous sinus separately. Sometimes the inferior drains into superior, and the most important is the central retinal artery, which passes from the retina inside the optic nerve sheath and drains into the superior ophthalmic vein. Of course, there is supratrochlear, supraorbital veins with superior ophthalmic. There is the infraorbital vein with the inferior ophthalmic. Some veins, superior palpebral, angular, not that important. Any infection in the face can be carried, resulting in cavernous sinus thrombosis. And when you have a carotid cavernous fistula, you have dilatation and engorgement of these veins. Again, inferior ophthalmic vein, draining into the cavernous sinus. Here the inferior is draining into the superior, and both are draining in the cavernous sinus. This is to show you the central retinal artery as it passes from the retina inside the substance of the optic nerve, passes in the subarachnoid space. As we said, the optic nerve in the orbit has 3 meningeal coverings and has a subarachnoid space. If the pressure increases in the subarachnoid space, it will increase in the subarachnoid space around the optic nerve. It will compress the central retinal vein. It will impede the venous drainage from the retina, and you'll find papilledema. That's why we say that the orbit is the mirror of the brain. If you see papilledema, this denotes an increased intracranial pressure because the subarachnoid space pressure is high around the optic nerve, compressing the central retinal vein. Surgical approaches. The orbit, as we said, is the site of large number of pathologies that can be divided as anywhere else: congenital, traumatic, inflammatory, neoplastic, and vascular. And pathologies can be also divided into purely orbital pathology, pathology from the bony orbit, osseous pathology, and pathologies with intracranial extension. Also, a variety of surgical approaches can be used to reach the orbit. The lateral orbitotomy, doing an approach from the lateral orbital wall. It is for anterior orbital lesions, has to be anterior, not posterior. Whether it is superior to the optic nerve, whether it is lateral to the optic nerve, or inferior to the compartment, inferior to the optic nerve, you can approach it laterally. As long as they are anterior, you can approach superior, lateral, and inferior compartments. The transcranial approach is used for the superior posterior. So if it is posterior and superior, reach it from the transcranial. If it is medial posterior, you can reach it also transcranial, orbital apex, and intracranial extension. So transcranial is good for the posterior lesions if they are situated superiorly or medially. For orbital apex lesions and lesions with intracranial extension, of course, you can continue your exposure of the tumor inside and the orbit and inside the cranial cavity. And the medial orbitotomy for anterior orbital lesions, as we'll see. And recently, the endoscopic approaches to the orbit is gaining more and more popularity. It was first designed for medial orbital lesions by our ENT colleagues through the ethmoid and maxillary sinuses, but recently it is used also for the lateral side of the orbit, as we'll see now. Lateral orbitotomy. you do a line and incision in the line of the glass from the lateral canthus posteriorly for 2 centimeters. Do not exceed this, not to injure the motor branch of the facial, otherwise you will fail to raise this eyebrow. And you can, according to the site of the lesion, which compartment, you can do an a superior lateral incision, or a lateral incision, or inferior lateral incision. No problem. And this is a detailed approach. After you do your skin incision, you will have to dissect the periosteum from the orbital rim, opening the temporalis fascia and reflecting the temporalis muscle posteriorly, then dissecting the periorbita from the lateral orbital rim and putting the drill holes before cutting in between, and then you you drill the orbital rim, and you have here the lateral compartment or the periorbita, the lateral part of the orbit, and you open it. You can expose the tumor according to its location, intraconal or extraconal. This is a view, operative view. We said here we did a superior lateral incision, not exceeding 2 centimeters posteriorly. We took the temporalis muscle and fascia posteriorly, and we exposed the lateral orbital rim, and we took the periorbita from the lateral orbital rim. We exposed the bone totally. And this is the part of the bone we have to take out to expose the lateral orbital rim for the lateral orbitotomy. And this is the lateral orbital rim taken out and prepared to be reimplanted again, because it is very disfiguring. And of course you open the part of the lateral wall of the orbit behind the orbital rim. You can take the bone, there is no problem, because it will be covered by the temporalis, but you have to get back the orbital limb not to disfigure the patient. And you do your job through the lateral orbitotomy. This is the extent of removal, as we said. The zygomatic arch and medially, more proximal to the frontozygomatic suture. Again, transcranial approach. Transcranial approach can be by different approaches to reach the roof of the orbit. The most famous is the lateral frontolateral approach, lateral subfrontal approach. You can do it from the eyebrow, you can do it by an incision behind the hairline, lateral subfrontal, or terional, or very rarely if you have bifrontal, if you have a lesion, for instance, a squamous cell carcinoma of the ethmoid and reaching both orbits. This is the classic subfrontal or smaller lateral subfrontal. You reach the roof of the orbit, you take out the roof of the orbit, you reach the periorbita, and you can work here for lesions situated posteriorly, whether medial posterior or superior posterior, or with intracranial extension or orbital apex. This is the view you can see. Of course, you don't see this view because of the fat, but this is the topography and the anatomy you will see from above. This is after you take out the periorbita, you find the 3 nerves, as we said before, the lacrimal of V1, frontal of V1, and the trochlear, supplying from the outer surface of the muscle. Only nerve supplying the muscle from the outer surface, superior oblique. Medial orbitotomy, you can do the incision here, and you can reach the ethmoid sinus, and sometimes when we used to do the transethmoidal removal of pituitary adenoma, we used to use this incision. It's no longer used now. And then you work for the lesion situated anterior and medial. So lateral orbitotomy, medial orbitotomy, endoscopic approach. As you can see here, the floor of the orbit, there is the maxillary sinus. As we said, the floor is formed of the orbital plate of the maxillary bone. So you can reach from the maxillary sinus, the floor of the orbit, and you can repair the floor of the orbit in blowout fractures, as we'll see. So the orbital endoscopy, as we said, you can reach sublabial, maxillary sinus, reach the floor of the orbit, and you sometimes when you have a blowout fracture of the floor of the orbit, and you get some herniation of orbital fat in the maxillary sinus, you put it back and you put a repair here, not to see double vision. So you can approach endoscopically the orbit from below through the maxillary sinus, and you can approach it transnasally, medial to the medial turbinate, and you can, from the other side, reach laterally as far as the orbital apex. So you can reach transmaxillary, the orbit from below, or the orbital apex also. You can reach it from below, transmaxillary. And here you can see the orbital wall, ethmoid sinus, the sphenoid sinus, and the lamina papyracea reach the medial wall of the orbit from medially. So you can do the endoscopy for the floor, reach the floor of the orbit, you can reach the orbital apex, and you can reach, of course, the medial wall. If there is a lesion in the sinuses extending to the orbit, you can reach the orbit from the medial wall. Lamina papyracea, ethmoid sinus, which is the lateral boundary of the ethmoid or medial boundary of the orbit, and you remove this orbital wall and you find the periorbit. So this is the orbital wall here, and we are removing the orbital wall, lamina papyracea. Taking out the lamina papyracea, from the ethmoid we can reach the periorbita, medial. So we reach the inferior periorbita and the medial periorbita. And the last one, recently we can use the endoscope even for the laterally situated lesions. This is as if you are doing the lateral orbitotomy, but you do not a horizontal incision, you do a vertical incision. This way you can introduce your endoscope and you can see the periorbita, and you introduce your endoscope between the periorbita and the lateral orbital wall. So we create a space by pushing the periorbita medially between without removing the lateral orbital wall or the rim. You leave everything in place and you go between the periorbita and the lateral orbital wall. And if it is situated laterally, you can see the tumor here, and you open the periorbita above or below the lateral rectus. Here is below the lateral rectus to see the tumor and take it out. Thank you very much for your attention. And the next lecture we're going to discuss the lesions of the orbit. I know it's not a part of the neuroanatomy, but because it's having a very peculiar characteristic, the orbit. So we will talk about the orbital lesions immediately after the anatomy of the orbit, and we hope to see you very soon in good shape. Thank you again, and bye.